messaging to patients and parents. SMART has been classified as an essential medicine. I tell all parents this. This isn't just a filling, Mom. I tell the kid this. Jimmy, I'm not just doing a filling, I'm putting medicine in your tooth too. It's an essential medicine. Glass ionomer heals teeth from the inside out. I tell parents and children that. Silver diamine fluoride and glass ionomer together provide a powerful combination therapy. Painful teeth and broken teeth with no bubble or blisters are good candidates for this kind of treatment, being SMART. Our goal is to stop bacteria in its track with medicine before it reaches the pulp and then seal up the tooth, fill the hole with a medicinal cement filling. In those situations, and this arose at lunch from two different people, two different questions that were really the same question. What if it's deep? And what if the doctor that I work with says, that's too deep, we need to go to pulpotomy, we need to do something else, it's too deep for SMART? And I would say, doctor, how do you know that? Are your eyes microscopes? No, they're not, and neither are mine, doctor. Anybody can extract a tooth and or do a root canal or a stupid pulpotomy. It takes a hero to save a tooth. And what would you do for your child, doctor? I know what I do for my own kid. I'd save the dang tooth. But I might send mom home or dad home with a written prescription after I find out if they're penicillin allergic, because I like penicillin because these are gram-negative bugs in these teeth. If they're not penicillin allergic, I prescribe Pen VK. And I send them home with it, but I tell them, don't take it. I only want you to take this. Mom, I only want you to give this to Jimmy if he gets an abscess, if it starts hurting, if you have a pounding toothache and I'm not available because I'm climbing a mountain, I'm ski mountaineering, or I'm surfing on a wave somewhere in God knows where, or I'm not going to be around because I'm on a long bike ride. I don't want Jimmy to suffer. Take the dang penicillin. And then make sure you call me. Here's my phone number. Here's my cell number. I am there for you and Jimmy. And tell me he's had to take the penicillin. We got to the party too late. I'm sorry, Mom. I wish you had gotten here earlier. I wish I could have seen Jimmy earlier. We'll take care of him. And we'll make sure that you have a good weekend until I get in on Monday, when I can either extract the tooth or refer him to have someone extract it or do whatever needs to be done. But because you got to the party too late does not mean that SMART failed or that SMART caused it. We have no idea, and we never will, no matter how good our instrumentation gets, of knowing whether we've gotten to the party too late. I have done so many cases, and you're going to see them right now, where you're going to say, are you kidding me? I wouldn't have done that. I know you wouldn't have done that, but you will. You will be doing what you're going to see, because you're going to believe in yourself, and you're going to believe in this medicine, and you're going to believe in the ability of teeth to heal themselves. It is always better to utilize a no-shot, no-drill system using SDF and glass ionomer medicines to halt and heal the cavity. It never causes the tooth to have further symptoms. If symptoms arrive, this is likely to have happened with or without SMART treatment. Next slide, please. Here is Graham Craig. Okay. Improved patient behavior and caries arrest. Partial caries removal with silver and fluoride and glass ionomer combined 45 years ago. The guy is like down here over my shoulder. That's amazing. That's amazing. And I said, Graham, when we got a chance to talk. And I got him off to the side. And he gave me that bottle of aqueous silver diamine fluoride and said, try it. And I was able to try it later. But I said, dude, you were doing this 45 years ago. What in the world? Next slide. I'll go to that in a minute. Let me finish the Graham Craig story, because I don't think it's on here. And if it's on here in the next couple of slides, then I'll make sure that I don't repeat it, but I need to tell you the story. He said, we were in the Bourne region, or Bork, B-O-U-R-K, Bork region, right, Steve? The Bork region of Australia. So these are Aborigine kids. And he said, when we came with the Land Rovers up the dirt road, you can see this, Luke, I know you can see this in your mind's eye. He's coming up to the school, and he says, they don't have any windows on the school. All the windows are open, right? Where you go, that's how it is. That's where he was. And he said the kids were jumping out the windows of the school. He says they saw our Land Rovers coming in. They knew we were the dentists. When we were finally able to round them up the next day, he said they spit and bit and punched. And you don't want to be spit on or bit by or punched by an Aborigine kid, John. He said, I invented what I did out of desperation. Necessity was the mother of my invention. 1978, he had aqueous silver fluoride that he made by himself under a tree that set on fire, fell on his roof, almost burned his house down. And then he applied glass ionomer on top of it because he could think of nothing else to get it done, because dental general anesthesia was impossible, pre-medication was impossible, and he did what he had to do. And now, all these years later, we have found out that SMART means pulp protection. This is from Singa et al. This is from 2011, Journal of Conservative Dentistry. Partial decay excavation of infective dentin leaves affected dentin that can remineralize by combining SDF and GIC in sync with the formation of odontoblasts. Huh? Go back to dental school now. What are odontoblasts? The formation of odontoblasts in the pulp. Odontoblasts are those little cells that form tertiary dentin. Huh? We have evidence to prove that SDF and GIC actually stimulate odontoblastic activity? That blew Jeremy's mind. Jeremy Horst said, did you read this? He sent me that study. I said, I've already read that study. He says, what further proof do we need? When infected dentin is removed, remaining affected dentin can be remineralized, and odontoblasts form reparative dentin in a way that avoids pulp exposures. That's why you can charge for SMART as IPT. Okay? That is indirect pulp treatment. That's by definition. Next slide, please. Okay, this is from Cower et al. This is 2015. High fluoride releasing SDF and GIC did not induce any inflammation necrosis in the pulp. Together, they have good tertiary dentin-inducing ability. Completely different researchers coming up with exactly the same conclusion. Based on these attributes, SDF and GIC can be recommended as IPT materials for the management of deep caries. So now I want to know from the Vermont Board of Dentistry why I can't have a hygienist, independent hygienist, do a sedative filling with SDF and GIC because you think she's going to do harm to the pulp? That's totally contrary to the evidence. Next slide, please. Next one. Okay. We also know that SDF improves. We have a study that proves FDS actually increases the bond strength of GIC. And interestingly, it does the same for composites. It doesn't decrease your bond strength. And you'll hear this from dentists all the time. Oh, I wouldn't dare put that in there. That would hurt my bonding. That's anti-bondodontist. That's exactly wrong, doctor. That's pseudoscience. You don't have any evidence for that, doctor. We have evidence to the contrary. Next, please. Okay, this is my tooth. Jeremy brought this to the Lawrence Livermore National Laboratory in Oakland, California. This is the best evidence I've ever seen of SMART because I treated this tooth. This tooth was extracted for orthodontic reasons. It's a permanent tooth. And I used Fuji too. And he took it to the lab and did an SEM, scanning electron microscope image. And here it is. You can see the SDF in the lower right-hand corner, and that's the pulp, guys. That right there is the pulp. That's how close we are to the pulp. And look at what the SDF did. It's the black spots. There's the zone of chemical fusion. Can you see it? You can see it right there. That white line. Okay? And there's the SDF again, the spots, penetrating deep, 500 microns into dentin. Next slide, please. I sealed out bacteria and nutrients. I sealed them out with the RMGI, and I created a hard foundation for the SDF. I'm sorry this didn't come out. That's a blow up of that, but you can see it. That's where I've sealed things and created a hard foundation. Next slide, please. Oh, there it is. There it is. Okay, so we have zone of chemical fusion, as you can see, the SDF scaffold of structural support created by SDF, super hardened dentin. So in the red is the higher density in his slides, okay, for the stains that he used. SDF and hardened dentin into protective dentin directly over the pulp. This is one huge hardened mass that protects the pulp. Next slide. Okay, so I'm at Canberra. Doug says, you got to go to Canberra. I don't want to go to Canberra. You got to go to Canberra. I don't want to go to Canberra. He says, if you don't go to Canberra, who will? If you don't do this now, who's going to say what you need to say? So we go to Canberra. And it's at the Westin in Denver. And it's a big hoopla rigmarole. And there's people milling around in the lobby. And I'm like, I don't even belong here. What am I doing? And I'm like cursing myself for even agreeing. But he twists the arm really hard, this guy. And I'm like, ugh. But he invites Steve too. And across this lobby, at least as long as this room, filled with way more people than there are here, here's Steve on the other end of the room, and he's waving a baggie. He's going like this, and this baggie's waving. And I'm going, what are you doing? And he goes, and he starts working his way, and we're pushing people out of the window. It might take me a year, but I'm going to get to him. And I get to him, and he hands me this baggie. And I said, what the hell is this? And those teeth were in there. He said, you did these. I said, I did these? You did these, he said. He goes, let's find a place. And I said, what do you mean? He goes, we need to sit down and look at these. And he hands them to me and he says, hang on to these. And we find this little coffee house, right? And on our way over, who do we bump into? Jeremy Horst. Jeremy, hey, yeah. Because he invited all three of us. So, all right. And we're all looking at each other like, and Steve goes, come on, we need to sit down. And we go into this coffee house, and geez, there's nobody in there because everybody's clinking their drinks, clinkety, and talking, and hugging each other, and stuff that people do, whatever. Okay? And we sit down, and Jeremy puts down a napkin like this. And he goes, you have your computer with you? Well, I always have my computer with me. It's out of a cop car. It's one of those ballistic, tough books. You can drive cars over it. It'll handle like 3 meters of water. He knows I have it. You can use it as a weapon. And I have it with me, and I slap it down on the table. And what does Jeremy pull out of his pocket, Steve?
A little microscope. A little microscope.
A handheld microscope. So what you're looking at right here is a paper napkin with a handheld microscope that he's plugging into the USB on my computer. And we're looking on my screen, and we're seeing this. And we have fork and knife and spoon, because it's a pretty nice establishment. Next slide. This is what we see. And with the fork, we're all three of us picking at these teeth. This little boy was a rodeo. He never made it to the dental chair. It was your office. Dad held him in the lap, knee to knee, like Luke and I showed you earlier. And the kid was squirming and crying and kicking and spitting and punching. And I did this under the most adverse conditions. I don't know if I used SDF first or if I used polyacrylic acid, Lee. I have no flippin' idea what I did, because this kid was a handful. And I never thought I'd be looking at these teeth. But here we are, 1.5 years later, they exfoliated naturally. This is why my kids call these black diamonds, because they are as hard as diamonds. Next slide. Now this is the slide I like the most, because you can see the scratches from the fork. Because I said to Jeremy and Steve, pick that out of that tooth, Steve. Get it out of there. You cannot get it out of there, grasshoppers, because this is one with the tooth. Say, Om, Obi-Wan. This is one. They are one. They are unified. They are not separate entities. This is not a composite sitting inside a tooth through micromechanical locking. It has become one calcified, pulp-protecting mass. And we proved it with these teeth in the Westin at that event that you insisted we come to, and I'm glad we went. Next, please. Now, you are going to see an example on a primary tooth done in India. Now, these slides are from a colleague of ours by the name of Meenakshi Kerr. Meenakshi lives in Mumbai. I have never met Meenakshi, but Meenakshi said she wanted me to share her slides with you. So I'm sharing her slides with you. This is a 3-year-old child who presented with pain and sensitivity, cried at the exam appointment, and did not want needles and did not want drills. Please look at that x-ray. Is that deep? Do you see that line of dentin right there? Pretty thin. Is the doctor you work for, those of you who asked me the question, going to say, that's too deep for SMART? Well, it wasn't too deep for Dr. Meenakshi Kerr, who I have never met in person, but who I have done a couple of Zoom meetings with and many emails. Next slide, please. So, she applied SDF a number of times. This is not same-day SMART. This is multiple-day SMART. And she got it dark and hard. Then, next slide, please. She applied silver diamine fluoride, and notice, she did not bother to separate the teeth. Wow. Okay, so Lee, was it your question about separating teeth? Okay, I just want you to notice that Dr. Kerr in Mumbai chose not to separate the teeth. What happened here? Next one. 18-month follow-up. Please look at that x-ray. It looks like she didn't get her glass ionomer all the way down in, doesn't it? But she got the SDF all the way in, we know that. But I'm sure where this kid was 3 years old and crying, she probably wasn't able to get the glass ionomer where she wanted all the way in. Next slide. Look what happened. Actually, that's immediately post-op. Look what happens at 18 months. Starts filling in anyway. It starts recalcifying. You start seeing radiopacity, where you had radiolucency in 18 months. Next. Look at 24 months. No additional SDF. And look at the difference between the immediate post-op. Remineralization. But it took 2 years.
How come it looks separated in 18 months?
What's separated?
The teeth. Is that a different tooth?
Probably separated.
They naturally separate, or did she go in and separate them later?
Oh, she went in and separated them later. Yeah, absolutely. I see what you're saying. I didn't know what you were saying. Yes, she separated them later. They aren't in the post-op, but then later on she started getting a rapport with the kid, and she went in with one of those interproximal saws. Yeah, you know what I mean. Okay, so it takes 2 years. So don't be removing smarts before you allow them at least 24 months to heal teeth from the inside out. And now if you're going to go back to the ridiculous interim and definitive argument, you're going to say, well, I like to put in definitive fillings. Well, what's more definitive than that? I'm sorry, that's as definitive as you get. Remember, everything's interim anyway. Next one, please. All right, now let's look at something even more dramatic. This is a 7-year-old, okay, with occlusal caries and a newly erupted number 30 with an occlusal smart done earlier on T. Deep lesion in the permanent molar. SDF done earlier on number T. Needle and drill phobic patient. Decision was to do for 30 what was done earlier for T. Next slide. So here she goes. She's pinning her SDF and she waits, different appointments, waits until it gets black and hard. Next, please. Then, after conditioning with polyacrylic acid, she applies Equia Forte, applied directly over unexcavated SDF-treated arrested decay. The patient was still intolerant of needles and drills at this time. Next slide. Here's the wet, unset GIC pressed down and slid across occlusal surfaces using a saliva-moistened finger. Next. Here we are immediately post-op and 1 year post-op. So on this kid, she definitely got it down there on the permanent tooth. Got all the glass ionomer down on top of the dentin. Go ahead. At the floor. Now look at the pre-op, immediately post-op, and 1 year post-op. Look at the calcification. Look at the radiolucency of that mass. I contend that she made a decayed permanent molar into a super tooth. That is a super tooth. Look at that. You can't do that with any other material. That's more calcified than a perfectly healthy molar. Next slide. So why not just stop after we apply SDF? Why do we have to go through this? Why do we have to get the glass? We can do this just with SDF, right? Because single agent therapy is not as good as combination therapy, because caries is arrested with single agent therapy, but cavitation remains, leaving a food trap. So combination therapy arrests and eliminates the food trap. Next. And tell me that doesn't look just like what you guys just did on those plastic teeth. That looks just like what you did. This is what you did. You covered the food trap. You avoided needles and drills. You arrested caries. You disinfected. You desensitized. You remineralized. You provided glass ionomer, which is a fluoride reservoir that is beneficial to the treated tooth and to adjacent teeth, according to the 2014 Seghetti study that is responsible for glass ionomer being called an essential medicine by the WHO. Next slide. Here's my friend theory. I love this. I don't know if you saw this, Jerry, when he wrote this. I used to be happy and proud of my aesthetic results in my first dental life. Now, gray, smooth smarts and black scars in a perfectly healthy mouth make me happy. That reminds me of you. because I think that's where you're at. When I talked to you last night, I said, he's done with his first dental life. He's on to his second dental life. And you've been at that FQHC for what, 10 years you told me? 5.5. 5.5 years. In 5.5 years, he ditched his first dental life. Congratulations to Colin, because he's there. He's there. He's already there. In his mind, he's there, so he's there. Because now his patients are going to have this as their benefit. Next, please. Okay, can we show Theory's smart video, please, Colin? I have many videos on smart, including Dr. Domenici's video, which maybe some of you have seen, which is very slick and has some really obnoxious music in it. This has no music in it, and it is anything but slick. This video is taken by Theory's daughter, whose name is Justine, who is a dental assistant that has been trained by her dad. And this is on a special needs kid. Go ahead.
Hey everyone, Ryan here, and welcome.
Whoops, that isn't it. Yeah, maybe somewhere in there. Yeah, try that. Try that one up there in the upper. Yeah, that one. Try that. See what happens. Oh, is that it? Okay. Son of a gun. Yeah, there you go. That's the guy. Okay, this is a special needs kid. He doesn't talk, so I'm going to talk for him. Or he says some stuff in French. I just want you to see how fast he's working. Remember, it's a special needs kid. He's applied SDF. He's applied his polyacrylic acid in pumice. He mixes his polyacrylic acid. He mixes his pumice with polyacrylic acid instead of water. Okay, he takes a cotton swab that is dampened with the patient's saliva. Do you see how he poked it into his saliva to make it damp? Okay. Now he's poking it around. Now he's asking the patient to bite. Okay. Now he's going to remove the excess. Watch this. Now Theory chooses to make spaces between the teeth. So he's going to honor the anatomy and the embrasures. And the first thing he does is he takes that Explorer, very dull Explorer, I might add, and he makes that line at the marginal ridges, right? And he takes off any excess. Then he takes floss and he runs it through while it's still wet. He slides it onto both sides. He's done. Now, obviously, the gum tissue is starting to bleed. This is a kid who is just terrible hygiene. Again, this is his daughter, Justine, who is doing the filming. And you've just seen Theory do a Theory smart case. Okay?
Did he apply Vaseline at the very end? Or
No. No, he did not. He uses the patient's saliva and only the patient's saliva. He's removing some more excess. And he's just dabbing things off, and he's calling it good. That's how quickly this is done. All right, let's go to the rest of the slides because you're going to see a lot of his cases. Here's what that looks like 2.5 years later. Look at that. It looks like what you guys did today on those plastic teeth. And look at the zombies. Look at that. And notice how he's applied glass ionomer sealants to the posteriors, right? Okay, next slide, please. By comparison, this is malpractice. Too much tooth structure should not be removed. Got to stop this, guys. Next. What does a decayed tooth need? What a tooth needs is really up to an individual practitioner and to the patient. Non-restorative care is recommended by the ADA, just as Dr. Doug Young just told you. Glass ionomer seals off cavities and eliminates substrate invasion, thus providing bacterial arrest while tooth structures harden with no shots and no drills. The dental profession is really struggling with this, guys. with the reality of it, because SDF is the first drug ever to be approved to treat tooth decay. Excessive drilling has become improper care. Next. This is a case report on SMART of a patient with Sorgen's syndrome, a case reported using silver diamine fluoride and glass ionomer, Dr. Doug Young, JADA, 2018. This is a quote from Doug's paper. Placement of a GIC restoration following silver fluoride application confers additional sealing and prevents bacterial leakage into the restored cavity, caries lesion, and dental pulp. Rather extreme. I'm sorry, I've only got 2 of these to show you. Go to the paper if you want to read it and see the rest of Doug's wonderful slides. You did this case with Alan, did you not?
Yes.
Yeah, so this is Alan Wong and Young. So Wong, and that title, JADA 2018. Pretty dramatic. All right? Next. Okay. This is from 1996, the Australian Dental Journal. Placement of a glass ionomer restoration following silver fluoride application confers additional sealing and prevents bacterial leakage into the restored cavity, caries lesion, and dental pulp. Next one. 2022, we have another study, STF and glass ionomers, high mineral density, formation of hypercalcifications. We see that in Minoxidil's cases, that's for sure. Beneath the dentin layer after STF and GIC, treatment was identified, which implies STF and GIC treatment could possibly strengthen tooth structures. Duh, yeah, I think, from what we're seeing in the slides and in the x-rays. Next. IADR session in 2021, more of the same thing. SDF, GIC, same appointment, in the same appointment. So this is for same-day SMART, which is what I usually do. Minimally invasive, low cost, does not involve the use of needles and drills, and thus is non-aerosol generating procedure. Next. I'm just showing you all these different papers. I don't want to hear about we don't have evidence anymore. We got tons of evidence, Board of Dental Examiners. Okay, conclusion on this one, another study, 2022, silver diamine fluoride is successful in arresting caries and can be used to increase efficacy of the ART technique in primary teeth. Clinical significance, it is recommended as a non-invasive approach to control dental caries with the ART technique. Next. Here are 5 different papers that prove MMC as health equity. I am so sick and tired of the agents of virtue who are after health equity by means of more levels of providers doing the same thing. I am pro-dental therapists. One of my best friends in life is a dental therapist who is sitting right in front of me. I respect and love him. I want him to train other dental therapists. Doug trains dental therapists. I want him to continue to do that, but not doing the same things that don't work. Dental therapists, more levels of providers, providing the right things for the right reasons is a whole different issue than just having more levels of providers providing the same thing. And when they want to see that MMC equals health equity and that they should lead with the medical management of caries before they go into state legislatures like they just did in Maine, saying we need more providers. No, we need more MMC by all providers. Go ahead, Doug.
I don't think the audience knows what you're talking about.
Uh-huh. You probably don't know what I'm talking about. This is a big political football right now. There are groups out there, mostly of ex-retired, my age and older. Imagine, people can be older than me. Scary, I know. who were in dental public health. And they think they're doing a really good thing by going out and promoting more dental therapists like Jerry out there. We need more dental therapists, but exactly like Jerry, who uses hand burrs and uses medical management as a first measure. Not that they shouldn't do drilling, not that they shouldn't do what dentists do, not that they shouldn't do as they're being trained, but as a first measure, first, against the disease, put the fire out, Chris. Right.
That's what the ADA is recommending.
That's what the ADA says.
I don't know if anybody's hearing that, but that's kind of what they're saying.
That's kind of what they're saying. So
Kind of what they're saying. It's totally what they're saying, but the ADA's got to keep everybody happy too, so they don't come out very strongly and say it, but they say, it's advised, it's recommended.
let's let Doug talk because he's in the field of teaching these dental therapists. So we have a top educator of dental therapists. Do it, Doug.
I'm sensing you guys know what the hell he's talking about right now. Say it simply is, we don't need dental therapy just to be more drills to drill more teeth. We want dental therapy to treat with MMC and minimally invasive dentistry.
Thank you, Doug. But I don't think a lot of them get into that business thinking that's what they should be doing.
Exactly.
Exactly.
That's the-
Did you say that again so everybody hears
I
that?
don't think the dental therapists go into dental therapy thinking that that's what they're going to be doing. They're thinking like, I'm going to get to pick up a drill and I'm going to get to cut teeth and I'm going to do all those things that real dentists do.
Because they don't know.
They don't know. So that's a fear when there's more and more people going to
But we're blessed because here's a guy who's educating them.
Who's listening?
Who's listening, he says.
Could you explain more what a dental therapist does?
A dental therapist,
Policymakers.
yeah, a dental therapist is a mid-level provider. It's like a nurse practitioner or a physician's assistant.
What all do they do? Dental therapy?
They can
Do it. He's the educator.
Okay, dental therapy was started because certain populations don't have access to care. Let's take an example, Alaska Native population. They may have a village out in the middle of nowhere in the tundra where ice is, and there's no dental practices out there, so they have to fly them to Anchorage, and by then it's too late. They have to, go to the operating room, whatever. So they devised, Mary Willard got dental therapy to be applied to the Alaska Native population. And so we trained non-dentists, people, almost out of high school, skipped dental school, 3 years of training. We taught them how to do basic dental needs out in the field, in their clinics. They could do simple fillings, simple extractions, simple perio, and that model has been working tremendously, and it's caught on, and now it's spreading throughout the lower 48, and there's a lot of advocates for it, and a lot of people that don't want it.
On the job trained, and now it's actually in schools where you go.
They have dental therapy schools that are getting accredited through the ADA, just like a dental school.
Jerry went to one in Canada. Jerry's a graduate of one.
The program I attended was the National School of Dental Therapy in Canada, and started in 1974. And I was an interesting case because I was like one of the last students that was personally invited by the pioneer of that program, Keith Davies, in 1989. So I was in the class of his last class of 1990 to 1992. So I've been doing dental therapy now for almost 34 years. And they were training dental therapists to go to the remote northern regions where they didn't have any dentists at all. And so we were trained in all the basics of general dentistry, other than orthodontics or the oral surgery that involved doing plaque removal. I mean, we did extractions, or we didn't do orthodontics or endo or those kind of things. But we did really 90% of what a general dentist would do in his practice.
But a lot of extractions, right, Jerry?
Oh yeah, we did a lot of extractions, but a lot of it was still just regular
I know.
composite or amalgam.
But you're not afraid to do extractions, are you, Jerry?
No, I had done 300 extractions in the Philippines before I was even accepted by Dr. Davies. I think that was one of the reasons he was motivated to, hey, let's get this guy over here. And I was really, really, really so thrilled and honored to be part of that program. In fact, they even covered the whole program as far as my finances and all that.
And not only did he do that many extractions, but this is a leader in MMC in his field of dental therapy. Go ahead, Doug.
So 2 more points. One is, addressing what John's saying, is I would go to a dental therapist in Alaska that I've trained versus going to a random dentist in the lower 48 because I know what they're trained. They're very skilled when they graduate from that program. I'm not sure about the lower 48, what the other programs are, because I'm not involved there. I'm only speaking for what I've seen in Alaska. Number 2, extending this further, if dental therapy catches on, one of my worries is corporate dentistry is hiring dental therapy because they're getting paid half as much as a dentist. So why would they pay a dental student that is $500,000 in debt to come and do their drill and fill dentistry, which they don't want to do anyway in their practices, in their clinics? Let's just hire a dental therapist to do the slave labor and just do more drilling. We'll pay him half as much and we'll make more money. That's not the vision of dental therapy that Jerry's got into this business for.
Nor your vision.
So I think we have to be careful in when we support dental therapy, what are we supporting?
Exactly.
And
That
that's
is
John's point.
That is my point. Thank you, Doug. See why I insisted he come? Yeah, Sarah.
In my nursing home practice in Washington State, we serve the whole state of Washington, and corporate dentistry has come in. And I used to say 8 years ago that if therapy came to Washington State, I needed to go back to school because there were so many patients that weren't being seen by traditional dentists. Silver Diamond came available to me. That changed my mindset. I'm not saying dental therapists aren't valuable, but they need to do exactly what Dr. Young is saying, and corporate dentistry is looking at those therapists as the cheaper reimbursement. So I do want to encourage everyone to think of our existing workforce and hygienists and assistants also to be able to do this MMC and operate to the scope of our practice, and therapists to operate to the scope of your practice, because if we're all being utilized to the maximum of our scope of practice, patients are going to be seen and they're going to be able to access dental care.
And by top of the scope of of their practice, what she just said, think of those words, top of the scope of their ability to practice within the licensure, within their provider level. I'm saying that MMC, Doug's saying, we're all telling you that MMC is a higher standard. What do you want? What do you want in your mouth? What do you have in your mouth? I know what Gordon Christensen wants. What do I want in my mouth? So I showed you Peter Villanos, who you met, Chris, and who you worked with, Jerry. When you left, these guys were in Buffalo with me last October, right? I lost a composite filling the day before I gave that lecture. An old composite filling that had an amalgam around it. I don't know who did that composite filling. I think my dad did the amalgam. And it was on tooth number 13. And I said to Peter in Buffalo, I need a glass ionomer filling. Where? He said. I said, on number 13. Let me look at it. He goes, oh, it's kind of sloping. I lost the whole lingual cusp. It was not sensitive. I said, I can wait. He said, no, come on over. So I flew back. He flew back. I was another couple weeks in Maine before I left. We just sold our property. And I stopped in Waterville with Kent, my brother, the orthodontist, because Kent wanted to see this. Peter did not use any local anesthesia. He did use a burr. He used because he had that sloping surface of that cusp, and he just wanted to freshen the amalgam around that because he says, I just think, and he wanted to use Fuji too. He said, John, you taught me. He said, but I'm telling you, I've used them all. And I like Fuji too. And I said, Peter, you're my dentist. Do it. And he did it. And it's there now. And I don't have any pain in it. And it feels absolutely great. So what would you want in your mouth? What is the highest standard? Believe me, I could have gotten a gold crown. I could have had an endo. I could have had anything I wanted. My dental community in Maine would bend over backwards for me. I chose the highest standard of care for my own mouth. What would you choose? Next slide, please. Oh, wait. Go back to that one, please. So these are 6 papers showing SDF and GIC as essential medicine being 1, protective of the pulp, and 2, as indicated for indirect pulp therapy. So when you tell me that your state of Vermont or Maine or whatever has a board of dental examiners that says hygienists can't provide this under whatever code they're allowed, sedative fillings or whatever, because it is dangerous or harmful to the pulp, I would refer them to these 6 papers, because there's where the science is. We're beyond the point of being intimidated by these people, because we hold the truth, and they do not. Next, please. We have literature defense for SMART done by registered dental hygienists as being of no harm, and as MMC as being a first measure towards health equity. Next, please. Okay, so how do we code for them? Sarah asked this earlier. Code as composite per surface, because the CDT book says that glass ionomers are considered composite material, and bill for indirect pulp treatment. Do not code. This is important. Don't get caught doing the wrong thing. Don't misinterpret me. Do not code for SDF as a separate service of SMART. It's a part of the SMART. Those of you that can remember amalgams, you didn't charge extra for the Copalite, but you put Copalite in there, right? But you didn't charge extra for it. It was part of the amalgam procedure. So when you're doing SMART, that's what SMART is, silver modified. It's part of the procedure. Don't try to get a little more extra money. You're getting plenty of money for composite per surface and indirect pulp treatment. Do not be greedy, or you will hurt all of us, including the children. Do this right. Charge the way it should be. But if you do SMART in a separate appointment, like we saw of Meenakshi Kerr's case, well, then you can charge for it every time you apply it, okay? And then on your second day or third day, whatever, however, multi-visit SMART, don't charge it again, okay? Okay, next slide. Okay. Single agent therapy, calcium hydroxide. Everybody, raise your hands, dentists here. You learn calcium hydroxide pulpotomies in dental school? Hands? Wow. And by comparison to me, you are children. You are children. You are little kids. I do not mean that in anything but the most respectful terms. You should not have learned that. We are so far past that. That is stupid. It is antibacterial properties have always been questionable. Look at the data. It's never, ever, ever been proven that they have antibacterial properties worth a dang. And it's likely to be ineffective under laboratory conditions. It is likely to be effective under laboratory conditions, but not in vivo. And it has piss poor adhesion. You can put calcium hydroxide on the bottom of the filling and you can pop it out by looking at it. You tell the patient, don't fart, that's going to come out. Right? I mean, come on. Calcium hydroxide under restorations is like building castles on sand. Do I have Evidence of that? You bet, from 2012. That's a long time ago, guys. Come on. We need to catch up in dental education. Next one, please. Indirect pulp treatment using SDF and glass ionomer. Now that's a higher standard. It kills decay-causing microbes. It attacks biofilm. It builds remineralized structural support inside tubules. It remineralizes remaining affected dentin. Then odontoblasts can form reparative dentin in a way that avoids pulp treatment and exposures. SDF and glass ionomer have good adhesion. They seal chemically, are structurally strong, supportive of overlying restorations, and both are resistant to recurrent decay. SDF and GIC under restorations create a solid foundation. From Singa, Remineralizing Efficacy of Silver Diamine Fluoride Glass Ionomer, Part 1 and 2, Journal of Conservative Dentistry, 2011. We knew this in 2011. And you're using calcium hydroxide and teaching that in dental school? No, I don't think so. Next slide, please. SMART can be as long-lasting or longer-lasting than conventional restorations. As I showed you, resin composite lifespan 6 years, glass ionomer 11 years. If asymptomatic, allow your SMARTs at least 1 to 2 years before replacement, so antibacterial and remineralizing processes can induce reparative dentin formation over the pulp that comes from odontoblastic cellular responses to those essential medicines. That's so critical. Don't be in a hurry to remove them. You don't know of anything that is more definitive. You've been told a lie. Face it. Don't shoot the messenger. Could be the worst day of your life. You'll look at this 10 years from now saying it was the best day of your life. I did it too. I would be the pot calling the kettle black if I were to criticize you. But after 35 years of doing it, I looked in the mirror and said, you were wrong, Dr. John. You were dead wrong. Now go and change it. And if I sound passionate and I sound like I'm a salesman, I ain't selling you nothing. This is called atonement for my own sins. Because I was there too. And don't think that you can't come around like I did. You can. You have. And you told me that last night. Okay, use radiographs to assure caries-affected dentin left on cavity floors is not growing. SMART can always be replaced by anything later if indicated, if patients want. Learn to ask the patient what they want. What do they want? It's not about what you want. Next, please. Next one. There is no such scientific term as interim and definitive. Please consider not using this misleading pseudoscientific terms, even though you may have learned to use them in dental school or learn these terms from others like the AAPD. All fillings are interim, none are definitive. Next, please. Let's talk about providone iodine. Okay. First of all, while we're doing this, I'm going to ask the lead person at these 4 tables to pick out one of these, and please put, there's tips in here, you'll find them under here. Screw the tips on to all of those while I'm talking, and then I want you to take each one of those. Let's open this up so you can see what I'm talking about. If I can see you didn't, that's okay. Bah. Get your knife?
I have a question about reborn box for you.
Oh, thank you. Oh, thank you. We got one more box. Here. Okay, so what I want you to do is I want you, the lead person, to take these and apply a tip to each one and pass them down the table. Ideally, and I don't know if I have enough, I want everybody in this room to have one of these in their hands, this little thing here in your hands with a tip attached to it, please. Okay? Thank you. Yeah, go ahead. You had a question?
So
That last slide has said if they didn't want to replace it.
Right. If the patient wants
So
to,
you got in for.
you can leave that in.
It could last up to.
And it's your obligation to tell the patient that their option is to leave it, and it's fine. It doesn't need. It's not indicated to replace it.
Or to take it out, they would just replace it with a composite.
Well, who knows what they would replace it with? It's up to the patient. You can say your options are. Okay, it's called PARQ.
Does that come in only one color?
Does what come in only one?
The glass ionomer, is it just like?
No. Okay, we have an important question here. Does glass ionomer come in only one color? No. It comes in many different shades. But what we would like to tell you, what GC would like to tell you about their glass ionomers on the, this is all about that. If you want a sheet on that, it's right here, okay? This is our rep right here, okay? Guys, it comes in different shades, but I want you to remember that all glass ionomers become more translucent with time. With maturation, they become more chameleon-like. So give it time. They all start looking more and more like the tooth in 3 months. So give it time. Does that answer your question? Okay. Now, iodine. Everybody, can I have your attention again, please? You're holding the iodine, and I'll explain it to you in a minute. What is iodine and how much can be ingested safely? Okay, iodine is an essential ingredient. Okay, 20 micrograms a day is necessary for a healthy life. If you don't get 20 micrograms of iodine a day, you get goiter and your neck swells up. And it's very uncomfortable and it's very, very unhealthy. So this is an essential nutrient, iodine. Providone iodine is a stable polymer of iodine that is activated by, of all things, saliva. Bada boom. And you've known providone iodine all your life. It's called betadine. That's all it is. That's all it is that you are holding in your hands. That is providone iodine, known chemically as PVP-I. It is not molecular iodide. It is not molecular iodine. It is iodine at 1 milligram a day is the average normal intake. Now, I'm sure almost everybody, because we're in the Pacific Northwest, has eaten nori. That's seaweed. Maybe you like it, maybe you don't, maybe you're all going yuck. But one of those little sheets of seaweed that you can get in Costco, you know, just one of those sheets, one sheet has 3 milligrams. I can go through 4 of those packets on my way from Costco to Safeway. That's how much I like nori. And don't tell me, I don't want to hear about how it's not healthy. Next, please, because I get that from dentists a lot. Iodine differentially kills cariogenic bacteria. Do you hear that? It differentially kills. It doesn't kill them all. Guess what? Neither does SDF. Guess what? Neither does GIC. That's what makes them such special medicines. They don't wipe all the bugs out in your mouth. They wipe the bugs out in your mouth. You're going to be one unhealthy human. It does this differentially. It's a miracle that it does it differentially. A total miracle. That we don't use it, it would be a sin against nature. Okay? So, next slide. Saliva activates that stuff in your hands. Betadine, you've used it before on wounds. You know exactly what it is. In situ, that means in vivo. That means in your mouth. It gets activated. It dilutes the providone iodine where it becomes more effective in its diluted form. Low doses of iodine are effective in killing bacteria. Next one. Okay, iodine prevents plaque from being sticky because it reduces polysaccharides. It is more effective than CPC, more effective than essential oils, more effective than chlorhexidine, xylitol, and sodium fluoride. Betadine. Have we been missing the boat in dentistry? It's like, huh? Iodine? Are you kidding me? Next, please. Iodine is effective, fluoride is effective, but here we go. Combination therapy. Guess what? They're more effective together than either of them are alone. Bingo. Hello. Combination therapy beats single agent therapy every time. When you get cancer, and we all will, are you going to get one chemotherapeutic agent or are you going to get the cocktail? You know you're going to get the cocktail. So hang on to your chair. That part of life is not for the wimpy. But you're going to get a cocktail, not one. You're going to have multiple agent therapy. And hopefully we'll be more advanced in our cancer therapy, but only through combination therapy, not single agent therapy. Next, please. Here it is. It's in your handouts. You've got it. You don't need to look at this right now. It even includes that thing that's in your hand, which is in the lower left of your handout. See, starting on the lower left, the lower part, that's all that thing that's in your hand. I've been helping Jeremy develop this for Elevate. Elevate took the lead on this. Why do we need that thing? Why do we need this when all you got to do is go to Rite Aid and buy a bottle of betadine? Because dentists ain't going to go to Rite Aid to buy the bottle of betadine. And because you got to give it to the patient to use at home, and you're not going to tell the patient to go use betadine because you're a dentist and that's against your rules. You aren't going to tell them to start putting betadine. But if we came out with a product that's a dental product that we can put on the market that costs way too much money by comparison to just going out and betadine, then guess what? Dentists will use it. That's why we did this. So dentists would use it. Do you need it? Hell no, you don't need it. You just need to go to Rite Aid. Okay, next. Daily iodine causes no changes in thyroid hormones, from the Journal of Endocrinology, 1988. 10% providone iodine is regularly used to prevent oral mucositis in cancer patients undergoing chemotherapy and radiation. 3 references. Providone iodine is used regularly by hygienists as an intraoral perio-ultrasonic irrigant. Hygienists have been using betadine in your mouth forever, and you probably didn't even know it. There are 0 reports of contact dermatitis from intraoral use. Next slide. In this study by Lopez in 2002, this is how slow dentistry is in understanding. We have 91% caries free in the treatment group from use of providone, iodine, betadine. Holy cow. Next. In this study, reported in Pediatric Dentistry in 2004. Gee, that was a while ago, guys. 18% recurrent caries at 6 months in the treatment group, 36 in the control group. Excuse me, 63. 63. Huh? Recurrent caries. Next. Combination therapy does more than providone iodine or fluoride varnish alone. Use them both. This is from Milgram. This is a cohort study. Peter shared this with me personally in Cleveland when we were doing the PCORI study. And he said, Providone, and he has all the data on it. He did this in a study in the Marshall Islands. This guy goes all over the place. He goes to Micronesia, he goes to the Marshall Islands, he goes to all these places. He never brings a surfboard, so he really pisses me off. And he won't take me with him because he knows I'd bring a surfboard, and he probably wouldn't get me to help with his cohort study because I would be surfing. So it's probably appropriate. But what he is showing is 210% more likely to have caries-free permanent molars with the use of providone iodine and fluoride varnish together. 210% more likely to have caries-free permanent molars. Next, please. This has got to be one of the most important slides I've ever seen in my life. I know that you have seen this slide, Shannon, but I assume that probably everybody here has not, other than Shannon and I. And I'm glad to share it with you, because I just saw it for the first time last week. So this is the work that Jeremy has provided for us. This is a summary of preventives. Xylitol in moms of 3 to 15 months, 74%. Fluoride varnish and providone iodine, 70%. SDF, 61%. And of all things, vitamin D and ultraviolet light, 50% prevention of cavities. Man, look at where Profies, MI-Pace, chlorhexidine, and daily self-flossing are. They're at 0. What have we been doing? I would study this chart, ladies and gentlemen. I would make a copy of this chart and put it up in your operatories and pay attention to it. We've been going down the wrong road for far too long. Next, please. Here's some evidence from 2019. No significant difference in prevention of new root caries lesions using SDF alone or providone iodine and fluoride varnish combined. Now, that's not SDF and fluoride varnish. That's not the Duffin technique. That's SDF alone, Steve. Okay? Next, please. Okay, let's go back to theory in Brussels. He uses it on anterior teeth instead of SDF because it doesn't stain. Next. So, it's good combined with fluoride varnish. It's good combined with glass ionomer, but don't apply it with SDF. You can't apply providone iodine and SDF on the same tooth because the iodine and the silver ions lock together, making them bio-unavailable in the tooth. Okay? So that's the important thing to remember about providone iodine along with this. Next, please. Contraindications. Under 12 months, that don't mean squat. That's just the FDA saying no supplements before age 1. Allergy to PI, it's not the same as seafood allergy, and we'll talk about that in a minute. What is important is beta thalassemia major. You gotta do a medical history. If they've had beta thalassemia major, you could kill them giving them the providone iodine. If there's an open wound, like extraction or whatever, you don't want that on open wounds. Advanced thyroid disease with iodine intake sensitivity, no providone iodine for those guys. PI together with SDF on the same tooth and teeth at the same time is a no-no. Next, please. Suggested frequency. For mild caries, none. For moderate caries, 6 times a year. For extreme caries, 12 times a year to be given at home. That goes home with mom. You train her in the office how to paint that on the teeth. Next slide, please. Here's the CDT codes for it. You got one D0602 for moderate caries risk, 0603 for high caries risk. Caries preventive application, that's 1355, just like SDF. We got 9630, we got 4381, and we got 99. I'm not saying that your state is going to pay for that. I'm not saying your insurance company, their insurance company is going to pay for that. I'm saying that that is a way that you can code for it. and should code for it. And from there, we fight for reimbursement, just as we have for everything else. Next. Okay. Myths. It stains teeth. The color disappears immediately. It tastes bad. It doesn't taste like anything. You have a betadine on your mouth, and I defy you to tell me what it tastes like. It tastes like nothing. Okay, if I'm allergic to shellfish, I wouldn't dare touch it. Absolutely false. There is no crossover between shellfish allergy and an allergy to providone iodine. Shellfish allergy is caused by proteins in fish. There's no fish in this bottle. There's nothing fishy about it. It's just betadine. Okay, next slide. Okay, I think we're done with part 3. Yeah, Luke.
One of the contraindications was open sores in the mouth. In the medical side of things, the only thing we use this for is irrigating wounds. Open wounds.
Exactly.
So it doesn't seem like that should really be a contradiction.
Well, it shouldn't be. Luke is pointing out it shouldn't be a contradiction with oral wounds or extraction sites, but what we've got is politics, FDA, and they're saying no. And why they're saying no, we're not exactly sure, but we want this product to fly now. It's just been introduced. Does this just not come out last week? Last week. You are the first group. This is history. You're the first group ever to hold this in your hands. We've got certain strict rules by the ridiculous people that are controlling things because they really don't want things to change. We will change that part. Just like we brought the science to bear on the shellfish allergy, because that's what we had to fight for a year before we could get this out. Because every dentist I ever put there, oh no, I was in Maine and this dentist, hey, I went to Georgetown Dental School, you can't give that to patients. What if they're shellfish allergy? That's a protein doctor. I don't care whether you went to Georgetown or Schmorgetown. It don't matter to me. You're wrong. Use the science and quit throwing your highfalutin whatever at me, because we got to stick to the science. If I'm wrong, then bring me the evidence, okay? And that's where we're at with the wound thing, okay, Luke? So I'm required by law to say it, and because I'm behind this. Even though I've never got a penny for this, I am not sponsored by this company. Jeremy asked me, will you help me design this thing? Because I am a fabricator. Because when I was a kid, if I wanted something, my father always said the same thing, and he was a dentist. He said, John, anything you want that we can go to the store to buy, you and I can make it in the garage. Okay? So that's what I do. I make bicycle parts for the bike industry. I design bicycles. I design surfboards. I design whitewater kayaks for every manufacturer you've ever seen on any river anywhere. Okay? My designs of bicycles and my designs of whitewater kayaks never brought me a penny, yet they are worldwide. Why? Because I didn't want the money. You know why? Because you got to pay taxes on the money. So what I took instead was product. So you come to my house to ride bikes with me, you're going to see some bikes on the wall, mister, and you're going to see some boats and some surfboards. And I have those and use those, and that's all I ever wanted from the deal. So I was asked if I would help to tweak this with Jeremy. And I'm proud to say I helped to tweak this with Jeremy with the support of Kevin Thomas. Thank you, Kevin, because we could not have done it without the money that you made at 3M before you sold it and opened Elevate and hired the wonderful Shannon and others and Haley to bring us what we have. Okay? All right.
I have a question.
Yeah, go.
So
You can go to the next, if you want. 4.
So I did an unpublished study using 1 minute brushing with povidone iodine had no effect on MS and LB. Peter Milgram's work showed good results using povidone iodine covered with fluoride varnish.
Yes.
So I'm speculating the contact time has a great deal of difference, because when we use povidone iodine in the operating room, we're putting it on the teeth over a 3-hour period.
Yes.
And we see tremendous results in that respect. So do you recommend, does Elevate recommend covering the povidone iodine
Yes.
with the fluoride varnish to increase
Yeah.
contact time?
Absolutely, to increase contact time. Everything that Doug just said is absolutely true. We want contact time, and that's why we cover it with the fluoride varnish, because we want to increase contact time. Does that make sense? Everybody square on that? Anybody else have any questions about povidone iodine? Yeah, go ahead.
Well, I've heard molecular iodine as a term being tossed around, and I don't think you know anything about it.
No, we want this polymer because it's activated by saliva, and it is betadine, not molecular iodine. Any others?
10% betadine is 1% iodine.
Exactly. 10% betadine is 1% iodine. Yeah, go ahead, Sarah.
So can you clarify, because we're talking SDF and now we're talking povidone iodine.
Right.
So is the PI used more as a prevention and the SDF is more?
They're both preventive.
So isn't the patient always going to want the PI and not SDF?
They may. They may. And you should show them that chart. And you should stick to that chart. And you should do what the patient requests.
The povidone iodine is also treating the biofilm modification of the mouth.
Yeah, say that. Say that in here. Say that in here.
The povidone iodine is treating the biofilm modification in the mouth, not necessarily a caries lesion. You can place it over a caries lesion like you're seeing here, but the overall is to paint
Good
it
point.
on all the teeth.
That answers your question directly.
Which also I'll give a plug here. Today's topic is more at the tooth level. So don't forget that MMC includes what I call CAMBRA, which is caries risk management at the patient level, using other products like antimicrobials, which this is part of, home care products, high fluoride toothpaste, carie-free products,
At the
things like
patient
that.
level.
At the person level.
At the person level.
Rather than the tooth level.
Than at the lesion level.
So there's
yeah.
more you need to learn about besides just today.
That's right. There is much more. And Doug is a part of another product called Caries Free, which is just a wonderful product. But that's more at the person level than at the tooth level. I'm sticking to the tooth level. I leave the camera stuff to Doug. I am pro camera. I am pro everything. Doug is pro. But I leave that to Doug. I can't. It's already too long. I'm sorry. We're still only 3/4 of the way through. So let me continue because I'm still at the tooth level, and we'll be done after this part. We're not gonna take it. We're not gonna take it anymore.
Let's play some geography.
Okay, everybody, we ready? Let's get going.